You can keep talking. We're waiting on another bus load to get here, so. Any mic check? Sound good? Everybody can hear me? Sounds good. Okay. So, welcome everybody to the third panel of the day, which will be titled The Atom in Healthcare. On this panel, we have three people from diverse backgrounds, which you're going to hear an individual presentation, and then we'll have time for a question and answer afterwards. So please do keep up the good questions. You guys have been very, very good and engaged. There might be another load of people to come in during the talk, but we wanted to get going so we can preserve the amount of time that the speakers will have. So without further ado, I'd like to introduce the speakers. First we have Dr. Patrick McGuire from New Hanover Regional Medical Center, Radiation Oncology. And we have Dr. Samantha Hedrick from the Provision Center for Proton Therapy in Knoxville, Tennessee. And lastly, Dr. Roger Sitt from the University of North Carolina, who I also took a class in health physics at NC State with. So, welcome everybody. Looks like the other group is going to be trickling in here. So, we'll give them. Open up that other door.
Sounds like you know your priorities.
Quick one. All right, I think we've trickled the majority in now. So, thanks guys for standing by for that next group to come in, and welcome to the new folks who just joined us. I'll do a quick reintroduction. This is the panel, The Atom in Healthcare. And on this panel, we have three people from diverse backgrounds. Dr. Patrick McGuire from New Hanover Regional Medical Center, Dr. Samantha Hedrick from Provision Center for Proton Therapy, and Dr. Roger Sitt from the University of North Carolina. So, without further ado, we'll get into the individual presentations, and then we'll have time for Q&A at the end.
Thank you, Levon. I appreciate this opportunity to speak with you. First, I'd like to tell you the dangers of a webcam. Any Tar Heels here? Some? Okay. Well, for the rest of you, I'm going to talk about a medical center northwest of this location. How about that? I'd like to thank Mr. Walther, who announced at the first session the importance of nuclear science and radiation science in medicine. So thank you for introducing us. So today what I'd like to talk to you about is how the atom is at work at one specific hospital in our vast universal healthcare system, and that is UNC Medical Center. So I'm going to use the term atomic, nuclear, and radiation synonymously. Obviously there are technical differences, but when you hear those words, I'm talking about nuclear science, radiation science. And I will just call UNC Medical Center UNC. The goal of this presentation basically is to inform you of how much nuclear technology is utilized in medicine and the amount of knowledge that's necessary to implement these technologies, whether it's in design of machines or operations or design of procedures and treatment protocols. And the knowledge that's necessary is going to directly affect the beneficial use of radiation science. And probably more important to you is that I'm going to talk about how many potential careers there could be in the medical field from the use of radiation science and nuclear science. So just as a quick background, UNC Medical Center is a 803-bed facility that serves more than 37,000 people a year. It includes several different hospitals and employs over 7,000 employees, including almost 1,000 physicians. So why is it important and where is it important in the hospital? Well, we're talking about three major classes: diagnostic procedures, therapeutic procedures, and something I'll call support services, which requires probably just as much knowledge, if not more, and personnel. So in diagnostic procedures, we're talking about radiology, nuclear medicine, orthopedics, urology, otolaryngology, many different departments. Also in therapeutic procedures, mainly radiation oncology, which Dr. McGuire will talk about, things that are done there. And then support services, I'm going to talk about our radiopharmacy and also a whole nother career, radiation safety. So for each of these three topics, what I'll do is discuss the equipment that utilizes radiation science to do its job, the staff that must understand the radiation science, and the number of procedures that utilize these radiation sciences. So all the data I'm presenting to you is based on calendar year 2015, so it's a snapshot of 1 year. But what I want to get across to you basically is, after this presentation, I would hope that you're thinking, wow, radiation and nuclear science really is important. And also, once you have that foundation knowledge, I hope that you also will say, wow, there's a lot of different things I could do, even though at this point in time I may not know exactly what interests me yet. So first, let's look at diagnostic procedures. UNC utilizes approximately 104 machines, including radiographic, fluoroscopic, bone densitometry, mammography, SPET, which is single photon emission computed tomography, PET, which is positron emission tomography, and CT imaging devices. We also have state-of-the-art PET-CT and PET-MRI fusion imaging devices. So UNC employs 158 radiologic technologists, 16 nuclear medicine technologists. We have 39 full-time radiology attending physicians, 12 radiology fellows, 31 radiology residents. And look at the number of procedures that are performed for the benefit of society. 183,000 general radiographic and fluoroscopic procedures, over 23,000 interventional procedures, over 54,000 CAT scans or computed tomography scans, over 24,000 mammography procedures, and over 9,000 nuclear medicine procedures. So next we'll talk about therapeutic procedure. UNC utilizes 7 medical accelerators for external beam radiation therapy, including a cyber knife, which is used for stereotactic radiosurgery. Basically, they're using a beam of radiation with many, many degrees of freedom to radiologically cut a tumor out. And also a Mobotron for intraoperative radiation therapy. What that machine does is when someone is opened up for surgery for tumor removal or something like that, the intraoperative machine administers electron beam, which will kill off tumor beds, cancer cells in a tumor bed, while the patient is actually opened up. Now, we do have 7 medical accelerators, but none of them will be dosimetrically superior to Dr. Hedrick's proton machine that she's going to talk about. UNC employs 11 authorized radiation oncology physicians, 12 clinical authorized medical physicists, 5 medical dosimetrists, 17 radiation therapists. These are people that operate the machines for the treatment. So this is a picture of a cyber knife. So it basically is a small linear accelerator on the end of a robotic arm. This is a Mobotron, and this is one of the 5 other Linacs that are used for external beam treatment. We perform over 3,000 distinct patients a year. So the number of procedures is difficult to say because a patient will typically undergo many procedures as treatment progresses. So we're talking about over 3,000 distinct patients a year. So we talked about diagnostic and therapeutic. Now let's talk about support services, which is just as important. So we have a bloody radiator, which contains a tremendous amount of radioactivity. So the picture shows a device that looks pretty benign. However, there's enough radioactivity in there to give somebody a fatal dose in minutes if it were removed from the device. UNC utilizes a 7 million electron volt mini proton accelerator, and we also have a larger 17 MeV proton accelerator for the production of radiopharmaceuticals for both diagnostic and therapeutic purposes. And again, these proton accelerators is nothing compared to Dr. Hedrick's machine. I will tell you, though, that the importance of these machines is very, very high, because in order to perform all those procedures that we talked about before, we actually have to have the radionuclides to do that. And right now we're buying it from external, we have been buying it from external sources, and so that raises the cost. So hopefully, as soon as we're fully up and running, we'll be able to supply all our own radionuclides. The cyclotron facilities are not yet fully utilized, but we presently employ, which means that we will employ more in the near future, an authorized nuclear pharmacist, 3 radiochemists, a cyclotron engineer, and an operator. And then the radiation safety office. Now, you guys all know that radiation is inherently dangerous, risky. And so if you think you don't really want to work with radiation, well, I'll tell you that there's a whole career out there that deals with keeping people and the environment safe from the harmful effects of radiation. And that includes our radiation safety office, where we have approximately 8 to 9 employees. So these are different occupations that require nuclear science or radiation science knowledge at UNC Medical Center. So you can see the list here. I won't read through it, but just think of the flexibility and the diversity of the potential careers you can go into if you just build that one foundation, a strong nuclear science background. So whether it's physics that you really enjoy or chemistry, it can all be utilized through the nuclear science pathway into some of these careers that are being that are necessary to run a large teaching medical center. So in conclusion, nuclear and radiation science technology and knowledge is invaluable in the healthcare industries. It is indispensable for diagnosis of disease or health conditions, as well as treatment of the disease. However, machines that produce radiation and radioactive materials must be used in a safe manner to increase the benefit to risk ratio. Exposure to radiation can cause harmful effect if not used carefully, not only to patients, but also to medical practitioners. So what I wanted to share with you is one personal note. I'm a nuclear engineer by education. All my degrees are in nuclear engineering, and I started out in the nuclear power industry, which you guys have heard a lot about in the first 2 sessions. I moved because the career was fairly flat back in the mid-'80s. This is long before you guys were born. I moved over to high-energy accelerators, and then I became interested in the medical field, so I moved into using my nuclear knowledge and radiation knowledge in the medical field. So that's just an example of how diverse and helpful this kind of education can be for you. Thank you.
Thank you, Dr. Sitt. Next up, we'll have Sammy Hedrick.
Hedrick.
Sorry.
Yes, that's all right. All right, thanks very much. Like you said, my name is Samantha Hedrick, and I'm a medical physicist at the Provision Center for Proton Therapy in Knoxville, Tennessee. A lot of you probably haven't heard of proton therapy. It's not necessarily well informed for a lot of patients. Insurance companies don't necessarily like it very much yet. Even physicians don't know about it yet. So I'm trying to get the word out about proton therapy. So after the Q&A session, I have bumper stickers, I have buttons, I have pens, whatever it takes to help get the word out. I don't necessarily care if you come to my facility, just know about proton therapy. So, as I said, I'm going to tell you about proton therapy, a positive, pun, alternative for a lot of cancer treatment. So, what is a medical physicist? We have the American Association of Physicists in Medicine. They have this big, long definition of what a physicist is. There's 4 things I take away from it. We develop improved imaging techniques. We develop therapeutic techniques. We design treatment plans, basically tell the protons where to go in the patient's body. And we monitor equipment and procedures that we affectionately call QA. My definition of a medical physicist is we're the behind-the-scenes people. We work with everybody and everything in the clinic, from physicians to therapists to dosimetrists to patients, even the treatment machines, to ensure that every patient's treatment is as safe and effective as possible. My background is kind of similar to Dr. Sitt's. I have all of my degrees in nuclear engineering, and I did an internship at my dad's nuclear power plant. No offense to nuclear power folks, I hated it. So that's why I went into the medical field and got into medical physics, and I've been there ever since, and I love it, so I recommend it. So to give you the background of proton therapy, I have to start with X-rays. X-rays were first discovered back in 1895 by a guy named Röntgen. Less than a year later, they were treating their first cancer patient. So X-rays have been around for 120 years. It's definitely the conventional method of cancer treatment. This is an early image of some physicist that is preparing the X-ray machine to take an image of a patient. He's got his hand in front of it, right here, right? So he is testing the quality of the X-ray and tweaking all of his parameters by imaging his hand every single time. Don't do that. Not a good plan. It wasn't until 1946 that protons were first suggested for treatment. At the time, they only had research cyclotrons, so they were kind of low energy, and they weren't really made to treat patients. So they were only good for shallow treatments, and they couldn't really compete with the X-ray therapy of the time. It wasn't until the 1990s that we had a dedicated hospital-based cyclotron that could accelerate protons up to 250 MeV. That's the same energy we use today. So that was the kind of first modern proton therapy. This image is a guy at the Berkeley Radiation Laboratory back in the 1950s getting a very early proton treatment to the side of his neck. It's a shallow target, so it's ideal. Now, photons contain X-rays and gamma rays, so whether you're using photons, protons, carbon ions, neutrons, electrons, whatever, the whole point is to deliver dose to a target, which in radiation oncology is typically a tumor. By delivering dose, you're damaging DNA, which is ideally killing the cell. There's two ways to kill a cell. There's a single-strand break or a double-strand break. If you guys have been paying attention in biology, you'll remember that DNA is made up of nucleotides, right? And they're matched. So if you break off one of those nucleotides, what's called a single-strand break, the cell has a template. It can come back in and it can repair itself because it knows what matches with that other one. That's why it's considered sublethal. The cell can probably repair itself. So say a photon comes in and hits a cell. Photons have low linear energy transfer. They've only got enough oomph to break off one of the nucleotides along the path. At this point, the cell can probably repair itself and it's going to be fine. So how do photons do damage? Another photon comes in. It does another single-strand break. Sometimes it even gets double-strand breaks. The cell gets so overwhelmed that it's either going to try to repair itself and do it wrong and die, or it's not even going to bother. It's going to die. The other option is a double-strand break. This is when you break off both of the nucleotides at the same time. The cell no longer has a template. So if it tries to repair itself, it's going to do it wrong, and it's either going to mutate or it's going to die. So now you've got a proton coming in here. A proton has high linear energy transfer. It can break both strands of the nucleotides at the same time, thus causing a double-strand break. The reason protons can do this is because they have mass and charge. Photons have neither of those things. So cell kill for protons are actually 1.1 times more effective than photons. So what kind of doses am I talking about? To kill prostate cancer, you need 78 gray in 2 gray fractions. A fraction is splitting up the total dose to kill a cell into smaller daily doses. The reason we do this is every day you give a lot of dose to the tumor and only a little bit of dose to the healthy cells. And then between fractions, the tumor can't repair itself faster than we can kill it, but the healthy cells get to repair themselves. So at the end of their treatment, tumor's dead, healthy cells have gone through repair. So, like I said, prostate takes about 78 gray. Breast cancer only takes 50 gray in maybe 1.8 gray fractions. Lungs are kind of cool. You can either do 60 gray in 30 days or you can do 50 gray in 5 days. Just another tool we have in our arsenal. Compare this to imaging doses. A CT is only going to give you 0.04 gray. An X-ray is 0.002 gray. It takes a whole lot more dose to kill a tumor than it does to see a tumor. Now, for those of you in nuclear power or in health physics, you guys deal with like millirad, millirem, right? There's 1,000 millirad per rad and 100 rad per gray. My dad works in a nuclear power plant. When I first told him this conversion, the kind of doses that we're dealing with compared to what he's used to, blew his mind. So, a lot of dose to kill a tumor. So how do we deliver this dose? Well, first we start with a cyclotron. He's got a little baby cyclotron. We have a big old person-sized cyclotron. And what it does is it starts with a little vial of hydrogen gas inside some magnets and an electric field. As the protons start to move in a circle around the magnets, they gain energy. They actually end up moving around 10 miles inside the cyclotron in circles until they come out with an energy of 250 MeV. At that point, this is going to treat to about 30 centimeters deep in the body. Not every patient needs to get treated to 30 centimeters deep in the body, so we do something called degrade. We stick a chunk of carbon in the path of the protons. The more carbon you stick in the path, the less energy the protons have coming out. This allows us to customize the protons for every single patient. We then, now that we have a customized proton beam, guide it using magnets to the therapy room. The patient's going to lay here on the couch. This couch has a lot of degrees of motion. It's actually the same robot they used to build cars in big factories. So this guy, very strong, a lot of degrees of motion. The cyclotron gantry here can rotate any position around the patient. So as the protons come out here of the nozzle, we can pick any beam angle we want that works best for every particular patient. So, what does the dose look like when it enters the body? Say we have a tumor here at 20 centimeters deep. It's about 5 centimeters wide. If we first want to treat it with x-rays, that's what the dose distribution is going to look like. As the dose from x-rays enters the body, it's going to build up to about 100%, and then it's going to fall off, in our example, to about 50%. 50% of the dose is not going to kill a tumor. So what they do is they put a lot of beams spaced around the patient's body such that when all these beams add up together, you get a high intensity inside the tumor and you've spread out all of this low dose outside of the tumor. Now let's use protons. Because protons have mass and charge, they exhibit something called the Bragg peak. What happens is protons enter here at the body with very low intensity and they don't give off much dose. They keep going deeper in the body until they reach a threshold. At this point, they give up all of their remaining energy at once and they stop. We can design these protons to stop inside of the tumor and give a very high dose. Now, if you'll notice, this peak is very narrow. It's not going to treat our 5 centimeter wide tumor. So what we do is we degrade the energy a little bit, put in another Bragg peak, another, until you add them all up and you get something called the spread out Bragg peak. Now you have a very high intensity, homogeneous dose across the tumor and low dose before the tumor. So this blue shaded area, that's all of the excess dose outside of the tumor using photons. A lot of dose before the tumor, a little bit of dose after. This is the excess dose from protons. Some dose before the tumor, absolutely zero dose after because we've stopped all of the protons inside the tumor. And that is the single most important aspect of proton therapy. We can give the same dose to the tumor, but significantly reduce all of the excess dose, which is going to reduce side effects, it's going to reduce secondary malignancy down the road. So, there's several ways to deliver proton therapy throughout the years. Our method is the latest and greatest. It's called pencil beam scanning. Imagine this very narrow beam of protons. We can use magnets to guide it around the patient's body and deliver dose wherever we want. So imagine you want to fill the cup with marbles. We do the same thing with a tumor and spots of dose. You're first going to fill up the bottom layer. We do the same thing. We fill up the bottom layer of the tumor with spots of dose. You do this whole way until it's full, and the best part is you don't have to put anything outside of the tumor. This is what our pencil beam looks like at our facility, and if you're quick, you're going to notice that our pencil beam is actually 16 millimeters. So we are less pencil beam scanning, more dry erase marker beam scanning. Doesn't have the same ring to it. So let's set up our hypothetical patient. This is our patient, this is their skin. We have a tumor here inside of their body and an air pocket before it. Now we have our scanning magnet with this very narrow beam, this 16 millimeter beam of protons. So what we do is using a computer planning system, we guide the beam first to the deepest layer of the tumor and deliver a single spot of dose. Then we move the magnets a little bit, deliver the next spot. That layer is done. We degrade the energy a little bit, deliver the next spot. We then fill up that whole layer. Now we have to account for the air pocket in the next layer. That's okay, the computer knows how to deal with it. And we deliver the next layer and all the spots of dose. Again, the best part is we don't have to put any spots outside of the tumor. So, when the whole thing's done, we have this great homogeneous dose across the tumor, low dose before, absolutely zero dose after. Here's a clinical example. This is a CSI treatment. It means cerebrospinal irradiation. It's a child who has leukemia, and we need to treat their entire brain and spinal cord. This is a photon treatment. You're going to treat them with beams coming from their back. And you want to get this reddish-orange target coverage across their entire brain and spinal cord. With photons, you get this great target coverage here, but all this dose that didn't need to happen. Compared to proton therapy, the exact same beams coming in from the child's back, Same target coverage across their brain and spine, absolutely zero dose after it because we've stopped all the tumors or all the protons inside of the vertebrae. This is the subtraction of the two. This greenish yellow area, that is all of the excess dose that did not need to happen for this pediatric patient. It's dose to their stomach, to their heart, to their lungs. All of that excess dose could possibly lead to secondary malignancy and side effects down the road. Here's another example. This is a head and neck treatment. Again, you're looking at all of the excess dose to the patient if they used photons instead of protons. This yellowish orange color is 25 gray. What does 25 gray mean? It means 12,500 head and neck CTs. It means 5 million dental x-rays. It is 25,000 times what the general public is allowed to receive. And if you go off the linear non-threshold model, it's a possible 96% additional cancer risk across the patient's lifetime. So this is my favorite example in honor of National Breast Cancer Awareness Month is left-sided breast cancer. There's a lot of data coming out that the heart, and especially an artery within the heart, this little bitty pink guy called the LAD, are very radiosensitive. Dose to the LAD as low as 5 gray can start to lead to increased heart risk down the road. Heart disease is already the #1 killer of women in the US. We don't need to be making it worse. Look at the photon distribution. The LAD is getting about 25 gray, 5 times what it's allowed to receive. With protons, absolutely zero dose. So by using proton therapy for left-sided breast cancer, we can reduce coronary artery stenosis, we can reduce secondary malignancy, and we can improve lung function. So in the old days of proton therapy, we used techniques called scanning or scattering, and they were only really good for small, sort of isolated targets, such as pediatric tumors, brain tumors, low-risk prostate cancer. And at the time, it was thought that 20 to 30% of all external beam treatments could have an advantage using proton therapy. Now we've moved into the world of pencil beam scanning. It's opened up everything for larger, non-contiguous targets, such as head and neck treatments, high-risk prostate, breast cancer. We can even re-irradiate areas that have already received a lot of radiation. It's now thought that more than 80% of all external beam treatments could have an advantage using proton therapy. So now that you're all educated, I have a terrible joke for you. Hopefully you laugh. So a proton and a photon go into a bar. They both have their first drink. The photon continues to order another and another and another. The bartender looks at the proton and says, "Hey, don't you want to keep drinking with your buddy?" And the proton says, "No, thank you, I'm good." Protons know when to stop. Thank you.
Thank you very much, Dr. Hedrick.
Thank you.
All right. Well, you guys just heard from two folks with different backgrounds from me. I'm a physician locally. Recognize a couple faces in the crowd, actually, because I have a son who's the same age as you guys. Played soccer with a few of you, I think, and may have gone to school with a few of you. I'm going to talk from the doctor background, and you guys feel free to interrupt me. I'm just going to speak really briefly and then answer any questions. So what I do, I'm a radiation oncologist, and I'll talk to you about the background of what you have to do for those of you who are interested in that and becoming a doctor, what a radiation oncologist does. But I'm just going to talk to you about one type of radiation oncology, and this is called stereotactic radiation therapy. And I'm going to talk to you about a patient, okay? So this lady is a 70-year-old woman. She's been smoking most of her life. If you don't remember anything that we talk about here today, please don't smoke. Okay. So she comes in. She's been smoking for 40 years, a pack a day, up to 2 packs a day. She has a cough, which she's probably had for years, but it's getting worse. She sees her general doctor, gets a course of antibiotics. They think maybe it's bronchitis. Doesn't go away. The doc's a little worried, so he orders a CAT scan of the chest. BX means biopsy, is consistent with adenocarcinoma. It's a type of cancer. And adenocarcinoma just means glandular cancer. So you can get adenocarcinomas of your prostate if you're a guy. You can get it of your breast if you're a woman or a man. You can get it in the lung and various other places. PET CT scan. Yeah. Oh, am I in the way? PET CT scan shows a tumor in the lung and the thoracic surgeon, which is a chest CT surgeon, the doctors that go to school to fix hearts and open up chests, they decide and they say, well, this lady's too unhealthy to have surgery, so she can't have it. So one of the other options for lung cancer that's localized, it's not huge or massive, is a stereotactic body, or SABR is another definition. But basically, it's high-dose focal radiation to the chest. And we do this quite often. It can be done with protons, like Dr. Hedrick talked about, but it can also be done with photons. And we use lots of different various radiation beams. So this is a CAT scan, a CT scan image of this lady's chest. And whether you're religious or not, I like to say God loves symmetry. So if you put this is an axial image to the chest, so the patient's laying down, their head's into the board, their feet are out towards you guys. This is their right lung, left lung, heart, spine, okay, aorta in the chest. This is abnormal. This is a cancer until proven otherwise in the chest, in the normal lung tissue. So it's asymmetric, right? It doesn't look like that, like the other side. So when a patient comes in, they can't have surgery, they have this SBRT treatment. This is our team of folks who treat them. And so radiation oncology. How many of you guys are thinking about a career in science? Raise your hand. Okay, good. So that's mostly why you're here, I assume. Probably most people in undergrad and college, whether you go to Carolina or State or where have you, have never heard of any of this stuff that you guys are hearing about. Radiation oncology, even in medical school, people don't know what radiation oncology is. So radiation oncology, basically, you got to go to 4 years of college, 4 years of med school, you do an internship, and then you got to do 4 more years of residency. So it's a long time before you actually get to be practicing medicine. But you don't have to. If you don't want to go to school that long and you want to treat patients with cancer, you don't have to go to school that long. Other folks that we work with, the RNs, usually they have their nursing degree. Great nursing school here. I know because I get to teach some of them. And then they get an oncology certification after that. So it's basically 4 years of college and then maybe a couple years on the job where they're doing some training. So you don't have to go to school for a gazillion years to work with cancer patients. Radiation therapists, basically they do their college degree and they learn on the job. So we have people, the actual people who put the patients on the table and get their treatment set up, they're radiation therapists, and that's a pretty good career. They have a good life. They don't have to go to school again forever and ever. Medical physicists, you guys have just heard, basically can have a master's degree, or you can go ahead and get your PhD. But most of the folks who are out in practice, like who work with us, we have 4 physicists in our office, and they are all master's level, so a couple years after college. Dosimetrists are the ones that basically help with they do the treatment planning, and they work for a couple years. Again, they go to school for a couple years. And then the surgeons basically are in school for as long as me, forever and a day. So this is a big trial. Again, this is more for the other folks and the professionals in the room, but radiation therapy for inoperable lung cancer. When we talk about cancer treatment, and my partners and I are very big proponents of this, we don't just do stuff to patients. We have to make sure that the current treatment, if we're going to test a new one, that the new treatment is better than what's existing. So clinical trials are the way we do that. And this is just one example of that, where they had 55 patients with early cancers of the lung, and they got treated in just 3 treatments. So you heard from Dr. Hedrick, some patients we treat for weeks at a time, 5 days a week for anywhere from 5 to 8 weeks. So it takes up a lot of their life. These are talking 3 total treatments to cure a cancer. And so you look at these numbers, their survival, ultimately a lot of patients with lung cancer die of cancer spreading elsewhere. It can spread to the brain, the bones, the liver, etc. But as far as control of the tumor where it was, you're looking at 90+% of getting rid of these cancers. And so I won't go through all this. This is what the patients have to go through, and you guys will be bored with that. But this is kind of what the patients are set up to look like, something like this. So they're in either a mold or something else. They have something on their belly to keep their diaphragm from moving so much so that their tumor in their lung doesn't move as much. And they get imaged in something similar to this. They go through a scanner, and we call it 4D CAT scanning because there's 3 dimensions of space and then a dimension of time. So that's 4. So you're watching the tumor move as they're in this position. And so then we do a plan that kind of looks like this. And you can see the downside of the low-dose radiation, and these kind of, all the radiation kind of is represented with these colorful lines. The high-dose prescription dose is here, but you can see what Dr. Hedrick was talking about. There's a low dose of radiation in this patient out here. In a 70-year-old patient, that's probably going to have no clinical problem. That's not going to cause her a problem in her life. But in a 7-year-old patient, you would really worry about that because low doses of radiation in a kid can eventually cause radiation down the road. So ideally, you would, that's when you would send it. If a child had a tumor like this, you would send them potentially for proton therapy. But in an adult like this who's 70, they're not going to develop their cancer from radiation if they were until they're 90. And most patients are, not living that long. So this is an example of what we look at on the computer as far as how well are we doing, and we have different targets of what we want to treat, and then we have other normal tissues nearby, like the heart, the normal lungs, etc. And so we want all our targets to be over there and all our normal tissues to be over here. And so this is just an example, before and after, show and tell. Here's the tumor, and here's 6 months down the road. You have a little bit of irritation of the lung, but the tumor's gone. And so last 2 minutes, I'll talk about we can do that in the brain. So the same patient with lung cancer comes back a year later, and they're having some mild headaches, and lo and behold, they have cancer in their brain. This is not rare. This happens very frequently, unfortunately. Most patients with cancers in the brain are cancers that have spread from elsewhere. Some people have primary brain tumors, and those are pretty bad too, but more often than not, exponentially more patients who have, quote, brain cancer, it's usually a spread from somewhere else, lungs, breast, etc. So when we do that to the brain, we set patients up like this, and they have this little frame. Sometimes we do it without a frame, and then they get scanned. And you can see these are kind of computer plans for a patient who has several tumors in the brain. So what do you think these things are? Eyeballs, right? Eyes. There's the optic nerves, the nerves that come back from the eye. This is called the optic chiasm, where the nerves cross in the brain, and then the nerves come back here. And this is the brain stem. So that's the part of the brain where if it doesn't work, you are dead. It allows you to breathe, etc. Then here's just in a different dimension. So this is called an axial image, and this is a coronal image. And here you see a big tumor that's behind an eye, and then these other tumors. And all these little lines represent arcs of radiation dose. So kind of like what Dr. Hedrick was saying, with protons, you can go in, and the dose stops here. With photons, we have to put radiation dose. You're looking at this on end, but it's basically a radiation arc. So if I turned this patient like this, you would see a whole big fan of radiation over a big arc so that we can spare all the normal brain tissue nearby. And this is just another show and tell. Here was the tumor in one patient. That's cancer until proven otherwise. And this is, 6 months or a year later. So just really 2 types of radiation treatment that we do for patients. And that's it.
Thank you very much. Any questions from folks in the crowd? Yep.
A good question. The practical answer is no, if you want to practice in the U.S. It's harder to go outside the U.S. and come back in. A lot of very bright foreign medical graduates, say from whether they're from Asia or Europe or what have you, may have been even practicing for years, and then they want to come to the U.S. and practice. Our standards tend to be a little bit more rigorous, compared to all countries, but a lot of those doctors have to go back, if you want to be a doctor anyway, have to go back and redo some of their training. So in practical terms, if you want to go to medical school, it's better to go in the States if you want to live here and practice here.
For medical physics specifically, the field hit a maximum about 10 years ago, and it was flooded, and they started pumping out all these students. And when I was looking for a job, 3 or 4 years ago, I couldn't find one to save my life. Now they've regulated a lot of the degree programs, so you have to go to an accredited program. So at this point, I feel like everything is sort of balancing out, and the jobs are going to start to pick up again. They've figured out exactly how many jobs they have and how many students they need to fill those jobs. So I feel like you guys are coming out, at least as medical physics is concerned, at a really good time, if that's the path that you want to go.
And if I can add to that too, we saw presented by more or less each of the three presenters how different fields of discipline can have application in healthcare as far as nuclear medicine and imaging is concerned, clinical and imaging both. So there is a wide range, as Dr. Sitt stated, that he came from the power industry and moved into healthcare from there. So
I'd like to add something as well. If you have a strong nuclear or radiation science background, I will tell you that most of those careers that we talked about, it's a lot easier for a physicist to learn biology than a biologist to learn physics. And that's just because of the nature of physics, I guess. But that's been my experience anyway.
If you ask, oh, go ahead.
I have to repeat the questions
I'm
for
sorry.
the
Repeat.
folks on the call. So why is proton therapy so exclusive, your question? And why isn't it more widely available?
So if you ask the general public, everyone's going to tell you proton therapy is brand new. We've been treating since the 1940s, like I showed you guys in the slide. The problem is that it's very expensive to build a new facility. A LINAC, I don't know, you can put in a LINAC for a couple $1 million. My 3-room facility cost $100 million. So it's very hard to get the capital to build a facility. Additional to that, insurance companies don't like proton therapy. They consider it experimental. A lot of physicians that are out there have surgeon backgrounds, so their first opinion is going to be send the patient to surgery. After that, they're going to send them to photon therapy because photons have been around for 120 years. It's hard to get people to change their minds and open up to proton therapy because there's just not a lot of support behind it yet. So that's why we're trying to get the outreach out there. It's like, look, if you can tell your insurance company, tell your senator, tell whoever you have that proton therapy needs to be better supported, because right now, left-sided breast cancer, very few companies pay for it. If you're over 65 and you have Medicare or Medicaid, they will pay for proton therapy. Most insurance companies will not. So it's really unfortunate that a lot of young women, a lot of men and women get turned away for proton therapy because insurance companies think it's experimental.
We're not going to have a head-to-head like brawl here, but I'll go with a little pro-con. Financially, clearly that's an issue for healthcare. $100 million facilities, that's why there's only a handful in the country. But I'll get men with prostate cancer who come in and say, should I go to Gainesville or should I go to MD Anderson for my prostate cancer treatment with protons? And the answer is, in my opinion, no. The clinical data isn't there. There's no head-to-head study that has ever proven that protons are better than photon treatment. In theory, protons are excellent because of what Dr. Hedrick talked about, the Bragg peak, et cetera. So you don't have any exit dose from the radiation. But when it's really all, the devil's in the details about photon treatment. And so with our computer planning today is dramatically better than it was even 10 years ago, and certainly when I started practicing. But the data has to be shown in clinical trials. Is this clinic, not just in theory, is this clinically superior? Do we cure more people? Are we having less damage, less toxicity to patients? You can show radiation doses all day, and in theory, protons are going to be better at least marginally, if not significantly, in a lot of cases. But the proof is in the pudding. Are we curing more people with protons, and are we doing less damage? And so if I was in Congress, or even if, God forbid, I was on the board of Blue Cross Blue Shield, put a needle in my eye, but no offense to anybody in that industry. But if I had to do that, I would want the data. And some of those trials are ongoing, so maybe we will, in which case, in 10 years, maybe we'll have facilities. And there are now actually $20 million instead of 100, which is a hell of a lot better. Oh, sorry, heck of a lot better. But because our treatment machines are 2-3 million, but 20 million is still, you're talking about 10 times the cost.
I have one little follow-up to that. So, anyway, so he is right. There are a lot of ongoing trials right now, but I have a little anecdote to share. My boss once told me at my residency that having clinical trials for proton therapy is a little like having a randomized trial on whether or not parachutes work. You're not going to throw somebody out of an airplane without a parachute to prove that parachutes do in fact work. So it's hard sometimes to get proton therapy clinical trials started because for a lot of treatment sites like left-sided breast cancer, like pediatric tumors, it is unethical to treat a patient with anything but proton therapy because we know what the side effects are going to be. So it's kind of a compromise right now. Yes, we need to have those trials to give the insurance companies information to back up our claims. But on the other hand, you don't want to randomize a patient to photons if you know protons are better for that site.
I'd like to add something as well. So in addition to the capital investment into a proton accelerator, you actually have to have a staff on hand to utilize the machine. It's not just you buy an accelerator and you run it and you treat patients. You have to actually have a staff of people to keep the cyclotron running at optimum capabilities.
Well,
so
probably,
that's why per procedure, and which is why maybe the insurance companies won't pay. For a single procedure that may have the same clinical outcome, the proton accelerated procedure will be much more costly.
Yep.
Question. In the back? What about the rest of the world in terms of proton therapy?
They're a lot more open. Imagine that. We have 20 facilities in the U.S. There's over 60 worldwide. Places like Japan, like Europe, they have embraced proton therapy. They've moved past proton therapy into carbon ion therapy. We're not even there yet. So they are well ahead of us in that respect. This is not going to be appreciated. So proton therapy has the option to treat as low as about 30 centimeters deep in the body. For most prostate patients, that can treat all the way to the other side of their prostate. Carbon ion therapy has an even better dose distribution than protons. It has an even sharper peak with an even higher intensity. However, you cannot go as deep in the body. So as one of the carbon ion guys once joked about, Americans are literally too fat for carbon ions. So it's terrible, but no, I mean, I think we're going to get there, but I feel like we need to embrace protons and then we'll move on. Sorry.
Other questions from folks in the crowd?
Yeah, I mean, the best treatment is is prevention, sorry. Is prevention. So, not smoking, et cetera. We have 200,000 cases of lung cancer in the country. If people didn't smoke, we'd have about 10,000. So prevention is clearly the best. But for other cancers like breast and prostate cancer, you live long enough as a man, you're going to get prostate cancer. There are lots of men who are in their 80s and 70s who have prostate cancer who aren't going to die of it. But those type of cancers, really, I think, as we move forward, gene therapy, immunotherapy, using our own immune system to kill cancer cells, that's a lot of the exciting work that's being done in cancer treatment. Not all less toxic, whether you're given protons or photons, not all less toxic than radiation or chemo, but soon they will be, I think. I think we're, I like to think of the war on cancer as more really a marathon, and each year we might take a couple steps. So we're getting there. We're a heck of a lot better than we were 20 years ago. Hurting less people as well. Assuming the doctors weren't unethical, which sometimes is a big assumption, but usually not. Most doctors are going to do things that they want to help people. Radiation, about a third of the people that we treat with radiation in a standard practice like mine are incurable when they walk in the door. And so we're treating them for symptoms. So, if he had pain in his bone, radiation can help bone pain. If he had cancer in the brain, sometimes we shrink that down so patients can function better. So that'd be the most common answer. Palliation is the word, really.
Good question. Other questions from folks in the crowd? Yes, Jim.
I wonder if you'd explain the difference between these types of therapies, what's called gamma. Is that something you could explain to us?
Gamma knife, I'm a huge proponent of gamma knife. Gamma knife actually uses cobalt. So in the old days of radiation therapy, when they weren't able to accelerate X-rays to as high of energy as they wanted, they used a radioactive material called cobalt-60, right? And the gamma knife is a very cool method of utilizing 192 cobalt sources that are arranged in almost a sphere. And you can put the patient, it's actually, you screw or bolt this halo onto the patient's head, and then you bolt them onto the couch so they can't move. And then you slide the patient inside of this sphere of cobalt, and what it does is it can highly, like sub-millimeter accuracy, pinpoint the tumor and deliver in a single fraction all the dose you need to kill the tumor. So it's really ideal for small brain tumors. You can treat 4, 5, 6 at a time, whatever it takes. So a patient with like small brain metastases, gamma knife is amazing. And that's actually a really good segue, because as much as I love proton therapy, it is not going to replace everything. And gamma knife is one of those things. Proton therapy will 100% never be better than gamma knife at what it does. So there's a lot of therapies that are not getting replaced. You're just supplementing a patient's options, and that's one of them, because gamma knife is fantastic. Brachytherapy. Brachytherapy also uses radioactive sources to treat the patient from the inside of their body. That's another thing that proton therapy cannot beat. It is so darn good at what it does.
Going back to, go ahead, Dr. Sid.
Okay, I'd just like to add that, the CyberKnife machine that I mentioned does a lot of the things the gamma knife does. The big disadvantage with the gamma knife is because of all the sources in it, it has to be under Homeland Security's enhanced security regulations. And yes.
Yeah.
Mm-hmm.
And every 5 years, when you have to do a source replacement, you get armed guards. That's kind of entertaining.
Going back to Dr. Hedrick's presentation, she showed how DNA is affected by the photon or particle in this case, where the DNA is affected by the imparting of energy onto that. And in the case of a gamma knife, you're using gamma photons, which are much higher energy than X-rays. So that higher energy photon can impart a greater amount of energy to the cell, to the nucleus, and into the DNA, and affect that. Similarly, protons, are being a massive particle, is like throwing a bowling ball versus throwing a flashlight at somebody. It carries a lot more mass, and you're going to be able to impart more energy to that recipient. Other questions from folks in the crowd? Got a few up here that I can take the speakers through. Yes, two of them.
I just want to discuss the last slide.
So giving advice to the young folks in the room, that was one of my questions.
Okay, so what's the point of painting their future and their life? When you say that, like, in 30 years, are you going to hate being in your life, or are you going to look back and say that you were glad you were a doctor?
It's a very good question. So I have two kids, one who's, my son's your age.
Sorry. Going to your future career, would you, in 30 years from now, look back on what you chose as your career path and enjoy it, or would you look back and not enjoy what you do?
Yeah. I don't want to slit my wrist. I hope these guys don't either. Slit their own or mine. But no, I think it's, I have two kids. One, my son's your age, and my daughter's at Carolina as a sophomore, as a chemistry major, and she kind of chose what she wanted. I didn't push her one way or another to medicine. There are some doctors who, because of all the changes in healthcare, whether it's Obamacare, et cetera, they are very down on things. They're doing, we're doing more paperwork than we used to 10, 20 years ago. That's true. There's lots of other changes for the good and for the bad. So some doctors are saying, man, this is terrible. I would never tell my child to go into healthcare and to be a physician. I don't feel that way at all. It's a privilege to do what I do. I make a good living. It took me lots of schooling to get there. I mean, it's not easy. It's not easy to do any of the things that we do, but just like in life in general, anything that's easy generally isn't worthwhile. If it's going to be worthwhile, it's generally not going to be. You know, you have to pass some obstacles to get there. But having said that, it's a great career. It's really quite a privilege.
I agree. I mean, how many jobs do you get to say, you know, I saved a life today? I got to use a particle accelerator to do it, but I got to save a life. So it's kind of a cool combo.
There's one question back here. What is the effectiveness of proton therapy in the number of tumors it kills versus those that it does not?
So if you go by our fraction schedule, we say that every day if you deliver on average 2 gray to your tumor, you're going to kill about 63% of the cells. Those cells every night they're going to repair, they're going to reorganize, they're going to change in their cell cycle, etc. So it's always an average number, but in that respect, protons don't kill any better than photons do. They're more efficient. Like I can use fewer protons to do it, but at the end of the day, at the end of your treatment with proton therapy, your tumor's no more dead. It's, I don't know, like we don't kill it any better, we don't kill it any faster, we just do it slightly more efficiently. So in that respect, protons are exactly the same as photons. We have the same cell kill.
It's also not as much as everybody in the room would like to say nuclear science and physics is all there is. That's not the case. So there's the biology of the cancer as well. So, yeah.
Hi. Mm-hmm.
So is your father still in nuclear engineering? Yes.
Yep. My dad still works at the nuclear power plant, Missouri, at Callaway. He is a mechanical engineer. He was a Navy nuke, and that's what got him into the nuclear power plant. And yeah, his plant is where I had the internship. Kind of broke his heart. It's okay. Oh.
It's always like, don't do it. It's like, I have
Like I said, I mean, that's kind of, I guess, my advice that I would have given later is that finding your career isn't necessarily finding what you want to do, it's finding what you don't want to do. Like that's why do internships, do shadowing, whatever it takes to figure out what you don't want to do. Because that's why I was like, I'm going to be a nuclear engineer. No. I had to do a nuclear engineering summer internship to figure out that's really not what I want to do. So it may not be for you, but you have to find out. Like if that's something you want to try, do it. Just to find out.
On the first day, were you like, for all this salsa, and like the next, you're like, no.
That's kind of literally what it was. I walked in, I'm like, best day ever! And I was the first intern they'd had. There was a group of 10 of us. And they're like, here's a pile of paperwork. This is going to take you the whole summer to do. I did it in 3 days. And they had nothing for me to do. Plus, I was like, nuclear engineering, I'm going to get to like play with control rods and stuff. You don't actually get to do that. Yeah, I don't know. I like the healthcare. I like being able to, and again, I love nuclear power, obviously. That's why I'm here. But nuclear power is still technology from the 70s, and they're advancing, and that's great. But I feel like with things like medical physics and healthcare, we are on the forefront every single day. We are always developing something new. With our careers, you can not only treat a patient today, you can do the research and the academic portion that's going to treat patients 10 years, 20 years down the road. We are always advancing. I think it's my favorite part is getting to treat patients of today and tomorrow. Sorry, I talk a lot.
That's a good, very, very good advice, and that speaks to the question earlier as to what advice. Now, something that I might add to that, in a plug for what we do in the power generation industry, is the utilization and the power of data. All of these fields generate a massive amount of data when something is imaged and something is researched into the volumetric spatial measurements of what you're looking at. And not only the data that's generated, but how it's processed is very important. For the computed tomography, you're reconstructing slices of an image using a computer to do that. And all of those methods, as Samantha said earlier, are also on the forefront and maturing very rapidly today in terms of what's capable. the better, the more intelligent and we are to utilize the information that we have, the better treatment we can provide with these clinical and imaging techniques.
I just wanted to say one thing, that not all
Yeah, sorry.
Very good point, Melanie.
people love it.
Not
Yay,
everybody
nuclear
who works in
power.
nuclear power hate their job. I love my job. Melanie clearly loves her job.
Okay, so he does like a lot of hard, so like, I mean, if you, oh my gosh. We'll talk after.
We have a post-mortem conversation here.
Yeah.
So, other questions from those in the crowd? One in the back? So after the patient has gone through the therapies, proton or photon therapy, does that affect their health following the treatment?
Yeah, it can, absolutely. So that's why you want to have the best plan that you can to minimize the side effects. And whether you're doing it spatially with your physics or whether you're thinking in terms of biology, what could happen, patients can have side effects of their treatment. And quite often you can get both acute side effects, which we usually say is in the first 90 days, and then they can get late side effects. So sometimes radiation can be the gift that keeps on giving. And so that's why we continue to see patients down the road. We've gotten much better about that, but for instance, if you treat a man for prostate cancer, you could cure his prostate cancer, but a couple years later he could get rectal bleeding or problems with his urination. So that's pretty common, and why we have to see patients back to help them if they have any side effects of treatment.
Good question.
On that note, a lot of our patients, just because they come for the proton therapy option does not mean that that's what we're going to give them. Every single patient goes through a very rigorous analysis to say, is this the best thing for the patient? Would chemo, surgery, photons, gamma knife, whatever, you name it, be better? Every patient is going to get the best, most effective treatment they can. It's not necessarily protons if they come to our center.
I have a question for the panel. What is the strangest question you have ever received regarding your field?
It's a toughie.
While you ponder over it,
Yeah.
I was shopping at Costco one time, and there was a lady trying to buy a watermelon. She said, her daughter was trying to buy the watermelon. She said, no, you can't buy that. And this was last year. You can't buy that. There's radiation from Fukushima in there. And I was like, ma'am, I assure you there's no radiation in that watermelon. She said, how do you know? I said, I'm a nuclear engineer. I work for General Electric. She said, okay, I'll believe you. She bought the watermelon.
What would you say if she asked for a
Well, then you're adding to the problem. Dr. Sid.
One of the strangest questions I got was someone in the hospital found out I was dealing with radiation stuff, and they said, how come so many reindeers died from radiation around Chernobyl? And I said, I never heard that there was enough radiation released to kill reindeer. And so she said, no, I have the article right in my cubicle. I said, may I look at it? She said, sure. She brought it over. Turns out that the article was about how the government decided, because reindeer was a source of food, to sacrifice the reindeer. So it wasn't the radiation that was killing the reindeer. It was people, the government, killing reindeer because they didn't want, for a good reason. The reindeer ate contaminated foliage and passed on radioactivity to people, but the government wanted to prevent that, so the people killed the reindeer, not radiation.
I guess for mine, it's not necessarily a weird question, but if I ever tell people, what I am, what I do, I say physicist, and they're like, oh, like Sheldon. I'm like, whatever, like Sheldon. So that's pretty much my day. Nobody knows who I am except for Sheldon from Big Bang Theory. It is. I may be Farrah Fowler, in all honesty, but yes.
I don't think I get strange questions about my career. I get strange questions from patients about treatment and strange thoughts about what cancer is and what can happen with radiation. And obviously there's a lot of folks who are, generally worried about radiation because they hear, all the bad stuff that from radiation. And so some patients come in just very fearful about that. And generally, after a little imparting of knowledge, that can help, but not always. And then in this area, there's a lot of folks who, unrelated to radiation, feel like they will come in, at least a handful of patients per year, and say, the Lord is going to heal me. And that's it. It's not like the Lord will heal me through modern medicine and working through you. And there's a lot of patients who say that, and that's very nice. But the folks who say the Lord is going to heal me and then don't get any treatment is very sad.
Yep.
Because then they come back 6 months or a year later when their cancer was curable, and now it isn't.
Yep.
And now we're treating them for an incurable cancer. That's sad.
Yep.
We like to think that technology is something that humans are supposed to figure out. So, tools in our toolkit. Any other questions from the crowd? Yes.
I'm sorry to hear that. It depends. There's several types of acute leukemia, and so acute leukemia in adults quite often is more fatal than in children. So in children, acute leukemia is almost a third of childhood cancers, and we cure almost all those kids. The vast majority of kids with leukemia, not all, but the vast majority of kids are cured. But in adults often get different types, and as much as we like to think we're tougher than you guys in some ways, we are not in terms of tolerating treatment. Children tolerate really tough treatment really well, and we don't. Maybe it's because of all the baggage that we have in our life, but that's a very good question. I'm sorry to hear that.
Is there a genetic genetic lineage?
That's pretty rare in leukemia. So that's a good question. I don't think I have a good answer for you. It can be. I mean, there are heritable cancers and inherited cancers. And so the most common one you'd think about would be breast cancer. And usually, the cure rates can be the same, depending, but it really depends on the type of cancer. But inherited leukemia would be fairly rare. So I don't have a good answer for that specifically.
Other questions from folks in the crowd? Risks for workers that work with these machines?
There are inherent risks because, radiation, too much radiation exposure is bad for you. But the thing to keep in mind is that radiation, although it is a carcinogen, is considered a carcinogen, is very, very weak, like compared to chemical hazards or biohazards. So one of the jobs of a radiation safety office is to make sure that people don't get too much more radiation than is necessary. And so there are regulatory limits to how much people can get. And on top of that, there's a philosophy that you never let anyone work up to the limit. So we try to keep radiation workers safe.
So before we close, I would like to go back to the question that was asked. Do you have a single piece of advice or an encouragement for the young people in the audience to dwell upon or consider?
I guess I can start. I think I said this in my presentation, but if you have a strong radiation or nuclear science background, I hope you could tell today that you have lots of flexibility. And even if you don't like the career you initially chose, you can change it. And having this strong nuclear or radiation or physics background will qualify you for lots of different careers.
Yeah, like I said, I am of the opinion that you have to find out what you don't like. And I have no intention of staying in physics the rest of my life. I'm going to open a bakery someday. So I'm all about changing careers, finding out what you love to do, and trying it all. Oh, I've been there, done that, so I'm going to open one. Yeah.
I would say in general, I think the biggest limits that you have in life are the ones that you put on yourself. And so don't limit yourself. Whatever you think your threshold is, whether it's academic, athletic, emotional, you can go beyond it. And so don't limit yourself.
Were you guys here in the first session this morning? Mr. Walter actually made a very good comment that even with his fine arts degree, he ended up in, utilizing nuclear science knowledge to the best of his ability.
And lastly, I might add to what's been said so far, follow your passion, establish a curiosity, and that curiosity may change through your life. I really love plants, and I like working in the garden, and that's something that I find is therapeutic after working in front of a monitor all day. So find what you're interested in. That interest may change, and embrace that. It may be baked goods, it may be, maybe trucks, it may be otherwise. Find your curiosity and let that guide you. Well, thank you all.